We have Dr. Shreesh Kumar sir, who's a medical superintendent of our Eye Foundation in Coimbatore, and he's an amazing surgeon. I mean, give him any type of case of keratoconus and he will do a DALK. And watching him and watching his videos has always been a pleasure. So over the next 10 minutes, I'm sure he'll show you where big bubble, manual, when and why.
Thank you, Shreyas. Thanks for the opportunity. And so my topic is DALK in keratoconus. Big bubble versus manual, when and why. So we all know the surgical management of keratoconus has changed, and we have success in DALK. In most of the cases now, the DALK has become an automatic choice for the management of keratoconus. It has replaced penetrating keratoplasty in most of the cases, and most of the cases which require keratoplasty. So these are some of the indications for keratoplasty in keratoconus, that is poor visual vision with contact lenses or contact lens intolerance with advanced keratoconus, and non-resolving eye drops or healed eye drops, and the percentage of patients with keratoconus undergoing keratoplasty is around 12% according to this particular study. And younger patients with the steeper keratometry, poor visual acuity because of the advanced keratoconus, and corneal scarring due to various reasons. In keratoconus, it could be because of the advanced keratoconus itself, you can have scarring, or post CXL because of the dense haze, or post CXL because of the infectious keratitis, the scar, or aborted melt. All these things can lead to decreased vision, and maybe an indication for DALK in keratoconus. So the common technique which we use is the big bubble technique, which was proposed by Anwar and Tikman. And now, like if big bubble technique is not possible, we can go ahead and do a manual layer by layer technique. These are other techniques proposed by different authors, and so they can be used if the big bubble technique is not possible. And whenever you are injecting the air bubble into the stroma, you can expect three types of big bubbles. The type 1 bubble, this is the type 1 bubble, and which is actually a white margin bubble, which is a strong bubble, and it has got a floor thickness of around 30 microns, which includes Duas layer as well as the Descemet's membrane. And the chances of perforation with the type 1 bubble is minimal. And this is the type 2 bubble, and this is actually a large bubble, thin walled bubble, and it's got a clear margin. So whenever you are seeing this kind of bubble, you should be very careful, because the chances of perforation is very high with these kind of bubbles, and you can rather convert it into a manual layer by layer technique. And this is the type 3 bubble, wherein you can see a mixture of type 1 and type 2 bubble. It can be a large type 1 and a small type 2, or a large type 2 and small type 1 bubble. It can be a combination of these two. So type 1 bubble, as you see here, it's a white margin bubble, and it is a strong bubble, and you invariably you end up with the DALK in these cases, and the chances of perforation is minimal. And most of the cases, around 80% of the cases, you can get this kind of bubble. So this is another case of type 1 big bubble. Just injected air bubble into the anterior chamber just to show that the bubble is forming, which displaces the anterior chamber bubble to the periphery. You can see here. So that is an indication that the big bubble is formed, and is a type 1 bubble which has got a thick wall. And I just want to show a few case examples. This is a case of keratoconus in a young boy. The right eye vision is 6/6, not improving with glasses, and this is the topography picture, and the thickness is only 271, and astigmatism is very high. Patient was not improving. There was a and this is the technique I usually follow in these cases. I inject air bubble into the stroma, and then after getting a big bubble, I do a superficial keratectomy, and then perforate the bubble, deroofing the bubble, then inject visco into the neck incision to keep the desmids away from all the manipulations. And with the help of a venous scissor, you dissect the posterior stroma and divide it into 4 quadrants or more than 4 segments, 5 or 6 segments, depending on your convenience, and go right up to the trephination margin. Once that is done, you prepare the donor tissue. Use a Excel sponge to peel off the endothelial layer, desmids endothelial complex, and then give a thorough wash and place the graft on the host bed and suture it. Usually suture with the 10 monofilament nylon, 16 sutures if the size of the graft is more than 8 millimeters, and less than that I use 12 sutures. And coming to the next type of bubble, this is a type 2 bubble. There is a scar here, and you can see the type 2 bubble forming. It's a thin walled bubble. It's a clear bubble and a clear margin you can see. And in these cases, one should be very careful because of the chances of perforation. A thorough preoperative evaluation, the slit lamp examination, as well as anterior segment to OCT evaluation to classify this keratoconus has to be done. And this is a classification, OCT classification of keratoconus, stage 1 to stage 5 based on anti-segment OCT. So up to stage 3A, you can safely go ahead and do a type 1 big bubble technique, and beyond that, because of the posterior stromal opacity, the chances of big bubble 2 formation is high in these cases. So it is better you go ahead with the layer by layer manual dissection in these cases, like stage 3B onwards till stage 5. So this is the algorithm for performing DALK in these cases up to 3A stage, that is the hyperreflective Bowman's membrane reflections. You can go ahead and do a type 1, usually you get a type 1 bubble, and you can go ahead with the big bubble technique. And beyond that, 3B, 4 and 5, because of the posterior scars, you can follow other techniques. You can do a manual dissection, or you can do a visco dissection or a saline dissection or whatever it is, and you can even continue with the DALK procedure. This is a case of 27 years old patient, again advanced keratoconus. The visual acuity is county finger 3 meters, and this is the topography picture of the patient. And this is the picture, the slit lamp picture of the patient, and this is the anterior segment OCT picture. You can see the scar here extending right up to the posterior stroma, but it does not touch the desmids. In these cases, you can expect a type 2 bubble, and this is what is happening here. This is the same patient. So you inject air bubble. It should be a deep, more than high. This is a type 2 bubble which is formed here. So once you recognize this type 2 bubble, you can safely go ahead and do a manual dissection. Instead of bursting the bubble, you can go ahead and do a layer by layer dissection, and you can be safe. You can go ahead and complete the DALK in these cases. This is how, this is the end of the procedure. And this is another case. This is a healed hydrops. The scar is paracentral. If it is in the center, it's better not to attempt a DALK. If it is in the paracentral area, you can safely go ahead and do a DALK in these cases. This is a anterior segment OCT picture of the same patient. You can see a notch here and posterior stromal opacity. And in this case, again, you can safely go ahead and do a DALK. The same patient. Here you know that there is a tear in the posterior desmids, posterior stroma. There is a scar. This is not for big bubble formation. This is just to create emphysema of the cornea, so that helps in the dissection. And these multiple bubbles, small bubbles, give us a rough indication about the depth up to which we can go. So you can do a layer by layer dissection here manually, and go up to predesmitic area and complete your DALK. So this is
if
the
you can try and
post-operative
conclude,
picture.
sir.
Yeah,
Yes.
post-operative picture is a 1-year post-operative picture of the same patient. This is the pre-operative ASOCT, and this is the post-operative ASOCT of the same patient. So the last case with the deep scar. So I'm not showing this thing. So you could complete the DALK in this particular case. This is the scar here. So usually these healed hydrop scars won't enlarge. That's the advantage. Because of the scarring of the margin, usually you won't get an enlargement of these scars. You can safely go ahead. You can maintain the antechamber with the bubble. And corneal melt. This is an aborted corneal melt following a CXL. This particular patient, and there is a flattening also. These are the cases which we can go ahead and do a DALK. This one particular last case is one particular patient who came after 7 years of CXL. This is the picture. She was actually 3 months pregnant, and we suggested DALK for this particular patient. This is the 4th month picture of the same patient. She didn't agree for the surgery. She wanted to complete her pregnancy and do it later. And this is how she came to us at the end of 9 months. This is almost desmetocele. And this is the ASOCT picture. She ended up with the PK. So we have to identify the stage of keratoconus. If it is an advanced stage with the posterior scarring, it's better you go ahead with the manual DALK. If it is an early stage, if the scarring is anterior, you can safely go ahead with the big bubble technique. Thank you very much.
Thank you so much, sir, for the wonderful array of videos. I request Dr. Himanshu to come and set up for his presentation. I mean, in hydrops cases, that's a very important point that you did mention, sir. If the scar is central versus paracentral with regards to the final visual outcome, although DALK is possible in both cases, the central scar might compromise on the final BCVA if the hydrop scar is quite central. So do you go ahead and do PK, or do you still attempt a DALK to see how the outcomes are?
DALK can be performed, but the BCVA will be less in these cases, so you are not going to give any justice, because with the PK, the visual outcome will be very good in these cases. So it's better to attempt PK in these cases with the central hydrop scar.
I think that's a very valid point, sir, and I think those are times when we should forego our own surgical ego and go ahead with the PK in such patients. Thank you so much.